And I'm fucking livid that we are stuck in the timeline where Alex Jones is right. As I said, democracy is a system that reinforces authoritarian ideals.
Why aren't the Amish afraid of COVID? Because they don't have TVs.
They were posting some crazy shit like months ago. Remember that?
You brought a freaking guillotine.
I did.
Being a victim of a tragedy doesn't make you an expert in public policy. Somebody telling them to stand up for their rights is disinformation. Kind of worse.
Oh no! Oh, okay, no. You want to make the world a better place? Have some babies and raise them to not be stupid.
Man, governments are not going to like this shit.
Ladies and gentlemen, boys and girls, activists and people of the internet, thank you for joining tonight for another episode of O'Donnell for Liberty. As always, I'm your host, Justin. Before we get started, make sure you hit that subscribe button and turn on notifications to keep up to date with future shows. And if you enjoy what you see, you can be an early supporter of this program by following the Patreon link in the description and signing up to join our production team today. If you want to keep in touch between shows, you can follow me on social media and join our Discord channel where you can chat with other fans about the show at any time. All those links are also in the description for you to follow today after the show. And first and foremost, a big shout out to our sponsor, SneckSwag.com, your home for all your favorite Liberty merchandise, including some awesome hoodies that are available just in time for the winter, where you can wear your libertarian messaging and tell people what you feel about the state and the conditions in the world around you. Now, tonight, we're going to be talking about pricing transparency in medical services, free market healthcare, the insurance racket, and what options there are for you as an individual to escape it, get around it, and make sure you get the treatment and care that you deserve for a price that you can afford without the government meddling. We're going to take some questions, so make sure you hit that like button, leave some comments, and tell us what you think in the chat, and give a warm welcome to tonight's guest, founder of the absolutely astounding Surgery Center of Oklahoma, Dr. Keith Smith. Dr. Smith, thanks for joining tonight. How are you?
I'm great. Glad to be on the show.
As I told you before we went live, I'm super pumped to have you on. I have been a fan of your work for a long time. I think I first heard of the Surgery Center of Oklahoma a few years ago when I was researching options for actually a patient of mine, a client of mine. I was helping them with their insurance, and it was something that Medicare wouldn't cover. And it came to the point that, like, I don't care where we're going to go, find an option. And I came across your website and your opportunity and what you do. For those who aren't familiar with what you do and those who are just tuning in and have never heard of the Surgery Center of Oklahoma, give us a little bit of background. Like, what sets you apart and what makes the Surgery Center of Oklahoma unique from other hospitals and surgical centers?
Well, the Surgery Center of Oklahoma was founded in 1997, 7 years after I'd had plenty of time to see the way the system worked. And we were founded with two very simple missions in mind. One is that we would never accept a dime of money from government. Philosophically, we saw that as accepting stolen property. And then the second thing was we felt like even if at times it might be slightly tension-filled and uncomfortable, we would always let patients know what they were going to pay us, what they were going to owe us. And so for patients that were uninsured, we decided we would quote them a bundled fee over the phone before they arrived. And we did that starting the first week that we were open, almost 25 years ago now. So we were very successful. We encountered lots of resistance. The hospitals, the insurance companies, government, they all hated us, still do. We just decided that's what we were going to do, and we were never going to veer from that mission. In 2009, I launched a website that had all of our prices on there, all-inclusive prices, with three goals in mind. One was so that patients that had sticker shock who were actually paying for their own care could more easily find us, whether they were uninsured, high deductible, cost-sharing ministry, member of a self-funded health plan, all the above. The second goal was to start a price war. I wanted people to look at our website and realize that if they ask a hospital who had just given them a $30,000 quote for an inguinal hernia repair, that they could buy it at our facility for $3,000, and that they should use that price to leverage a better deal in their hometown. So we really did want to start a price war. And then the third thing, I don't pretend to understand all of the scams operational in this industry, but there are a lot of them. But our third goal was, if we post these prices, will we better understand why, as a facility that's cheaper and better, we don't have a line around the block demanding our services. So I would argue all three goals have been accomplished with the very radical, but at the time what seemed like very simple move of just saying, here's what we do and here's what we think it's worth.
Yeah, and that's something that really struck me as unique when I first heard about you, was that your prices were your prices and people had the ability to shop and comparison shop, because it wasn't just, hey, we're the only game in town, this is what we charge, deal with it. It was like, hey, this is our costs. You can go, if you can find a better deal somewhere else, you should go somewhere else. That's something you never see in medicine. And one of the biggest pushbacks I've gotten from people when I talk about free market medicine is that, like, medicine is an essential service. You don't necessarily get the chance to comparison shop for a lot of things that you do need to go to the hospital for, because the ambulance driver is not going to ask what hospital you want to go to. So, like, you've seen success doing this with non-emergency care. Do you see any kind of potential, or is emergency care something that's completely separate in your mind that isn't a free market because it's not an elastic demand? It's a immediate demand and people need it covered immediately and they don't really have a choice of where to go.
Yeah, well, I like to tell people that the free market is like gravity. It's always operational. You can never turn it off, and you're either in sync with it, which means you're reaping the bounty, or you're not in sync with it, which means you're just receiving its consequences which are severe. So the idea that the market is not working when someone's in an ambulance, I think, is flawed, because the hospital that takes advantage of a patient who's unwilling or unable to defend themselves against predatory pricing, that hospital should suffer real reputational damage and bruising from taking advantage of people who are unable to financially defend themselves. So over time, the market should be at work, where people know, if I ever have to get in an ambulance, be sure to tell them not to take me to facility Death Star, because they're going to bankrupt me. And
right.
The market would put a black mark even on a hospital in a situation like that. So the vast majority of medical services that are delivered are shoppable. It is the rare instance that is not. But I didn't actually make this point originally. The first person I heard say this was John Stossel. And when I was visiting with him, he said, the reputation should be destroyed if they're preying on people that are not able to defend themselves. And in a market that had unfettered entrance for new competitors, that would happen. But it's so highly regulated, intentionally so, with regulations created and written by those who are actually in the cartel. It makes it more difficult for competitors to enter the marketplace. So, when in doubt, the government, the state is always the bad guy.
Now, when it comes down to it, what you said, though, there was their reputation should be damaged. That is a market consequence, and reputation is a form of currency in any kind of market. But I feel like the reputation of the pharmaceutical industrial complex, the health medical complex, and what your average everyday American sees as the nebulous that is medical care and hospital care in this country is already so low that it can't get damaged any further. With the exception of, like, I live in southern New Hampshire, an hour from Boston. I know we have like 8 of the top 10 hospitals in the world within an hour's drive of me. And I'd get mad if they sent me to Metro West Hospital instead of Brigham and Women's or Mass General or something like that. But like in your average place, is there really that much of a reputation for one hospital over another, given the negative perception that people already have? Can there be more negative damage on the industry as a whole?
I think there can be. I equate it to the idea that, government is really in trouble when it loses the consent of its citizens in quotation marks. So hospitals really will get into trouble when people put their foot down in a really hard and effective way and decide not to patronize them. So I think it can get lower. And, even in facilities that have big names, you have to be careful. They may have a big name and they may have 5 stars and they may be really good at something, but for the particular service you require, they may be terrible. So they're, it's typically not 5 stars all the way across, but, facilities get dinged and their reputation eventually catches up with them. I think about the timeline for reputational damage, though, in this industry is a little bit like geological formation. So it happens. I'm seeing it start to catch up, but I've been doing this a long time. But it's beginning to come around. Those who don't subscribe to mutually beneficial exchange eventually pay the price for that.
Now, that reminds me of something I've heard you say in the past, is mentioning that it takes so long for these negative opinions to form and takes so long for these negative reputations to have market consequences. I remember hearing you say something along the lines that you had felt that you were nothing but a tool in an enterprise designed to devastate people financially. And that's been happening for decades, and people are still not putting their foot down in a hard and fast way. You put your foot down in a hard, fast, and incredibly effective way, but the majority of people still aren't aware of the option to do that. Yeah,
I think I said accessory to a crime or an accomplice. I
just remember when you said it. I had watched that interview, and while I was working in insurance, I was working for one of the big name insurance companies at the time, doing plan design and underwriting, and I was like, huh. And at the time, it didn't click with me. A few years later, I thought back on it, and like, yep, that makes a lot of sense.
Well, you have to understand, the system is not broken. The system is working precisely as it was designed to work. And it's working like it is because so many favors have been auctioned off to the industry in Washington, D.C. And Uncle Sam's driving the getaway car every time someone gets robbed by this industry. Everything that people in the United States hate about the system in this country is a creature of government. That's why I've never really understood why people want to just throw the car keys to government and just let them have this industry. Everything we hate about the industry is a product of state intervention. So, it does take people a while to change their paradigm. The Free Market Medical Association is a very libertarian Austrian organization, and our theme at this last year's meeting, just a couple of months ago, was, are you ready for the red pill? Are you ready to wake up and acknowledge that, it can be different. And when people decide it is going to be different, it is. And I'm here to tell you that with my finger on the pulse of this free market movement, it's going the right direction. I'm actually very optimistic. The scrutiny is finally beginning to land on where it belongs. It's no longer putting a tinfoil hat on me for posting prices. Now, supposedly, a hospital that doesn't post prices is supposed to pay fines. That's a real 180 of the narrative, whether it ever happens or not.
So the crazy part about that is I remember when Trump's executive order came out and it was requiring pricing transparency up front. And I was like, that's incredible. That's amazing. Maybe this will take off nationally. Maybe this will be the new standard for what people do. And then I started helping some of my clients and patients when they were going through and dealing with their local hospitals and requesting for them. It's like, okay, what's the pricing transparency? And I'd get back a sheet. It's like, oh, for colonoscopy, if you have Blue Cross, between $300 and $700. If you have Aetna, between $900 and $1,400. It's still just giving people a broad range depending on what insurance they have. Nobody knows what it costs.
Yeah, I'm opposed to mandates of all kinds. I would just as soon market mete out its consequences. The problem with price transparency mandate, and my friend Jay Kempton and I both predicted this, was that it would afford unscrupulous legislators, which is basically all of them, an opportunity to sell exemptions.
Right.
And that's exactly what happened. Hospitals just decided they were going to pay fines, and the big boys can pay the fines. Mm-hmm. And the little guys struggle with it a little more. And all that does is lead to industry consolidation, which is bad. The other problem with the mandate is it afforded the cartel an opportunity to redefine the phrase price transparency. And they have successfully done that. So now it's exactly as you described. Now price transparency is the patient knows what their out-of-pocket is, not the price of the actual service. So I would argue those two consequences of the mandate are manifest. The good news is the mandate changed the narrative. So now those who won't post prices are the weirdos. They're the ones that are getting the scrutiny, and those of us who are posting prices are seen in a more positive light. And I think that the industry executives I'm talking to, even hospital administrators, know this is inevitable. They're going to have to step up and be more price transparent, or it's just going to be more and more problematic for them. But the market's powerful. These ideas are powerful, and it's hard. And it's hard for the buyer, the sovereign buyer, to look away from cheaper and better. American people are good shoppers. They want to know, and they know if someone won't tell them how much something is and somebody else down the street will, that something's very wrong.
Yeah, to that point, Americans are great shoppers. And I used to argue if Americans got an itemized bill that told them where every dime of their income taxes went, they'd just wholesale stop paying them. But that brings up the point to me, as someone who worked on the insurance side of things with the underwriting and the risk management and negotiation from the insurance company's point of view. A lot of people in my field and with my background struggle to understand how pricing transparency can work, like how you can come up with your prices, because a lot of the prices aren't determined up front. They're determined after the fact, where we would get a bill from the hospital that would be based on Medicare's usual and customary rates for a service, and the Medicare rates would be altered and changed on a monthly basis depending on the usage of those services in a given geographical area. And then we would negotiate it down to our usual and customary rates from the individual insurance company and have a back and forth with the doctor about whether or not they're out of network. And like, it would sometimes take weeks or months to settle an individual bill to figure out what it cost after the fact, because there were so many moving parts in something like a surgery. Because oftentimes the anesthesiologist charged separately from the surgeon, who charged separately from the facility, who charged separately from the nursing pool that helped assist, who was charged separately from the rehab ward where they stayed for 3 days after the surgery. And it was a nightmare to come up with a price, even on the inside. How do you come up with your prices up front? How do you determine them so exactly?
So years ago, I had a big backyard and I wanted a deck built. And I called this carpenter who was recommended by a neighbor. And he came out with a piece of paper and a pencil and a measuring tape. And he spent about an hour in my backyard and then came up to me and said, "What do you want it made out of?" And I told him what kind of wood. And he goes, "Nah, it's probably not a good idea in this climate. Why don't you consider these two things?" So I told him what I wanted then. And he said, "Well, I'll call you in an hour." So he called me in an hour and told me how much that was going to be. More remarkably, he showed up a week later with all of the lumber pre-cut and just did it. And that was the price. So I think about him all the time because he had not, that wasn't his first rodeo.
Right.
He had done that before and he knew. And he also knows there are going to be some jobs where when he's digging the post holes, he's going to run into rock and it's going to be a little bit harder. So he adds a margin for those outliers and that difficulty. And I had this conversation with him because I was contemplating putting our prices online. And he basically said, I put a margin on it. And if I'm wrong, the next job I quote is different. So there is nothing about me posting the price for an inguinal hernia repair on our website at $3,060 that locks me into $3,060. If after we do 6 or 8 or 10 of those, I realize I'm wrong, I'm actually not wrong. But if I realize I'm wrong, I just change it. And so, if a hospital looks at 4 or 5 or 10 of their last hospitalizations for any given diagnosis or surgery, then they have a range. So you pick the range and pad it if you want. And if you want to be more competitive, then make sure your margin is thinner. But hospitals know what things cost. All they got to do is look back at the last 10 they did and maybe pad it with some difficulty outlier margin and know, well, we're going to win big on a bunch of these because we have this padding on there we're not going to need. And we're going to break even on some and we might lose on some. But overall, we think that this will be attractive to consumers and we'll be ahead. What hospitals like to do after the fact is add every single thing up and make sure that they hit a grand slam on every single patient that enters the doors. And that's not the risk that an entrepreneur takes. That's not how the market works. You have to send a signal into the marketplace that says, you declare your value, what you think it is, and then you see if the customer actually agrees with your value determination, because ultimately value determination is subjective. But I think about this carpenter a lot because in an hour, he knew exactly what he wanted to charge me. And I don't know if the way I do my pricing is I call a surgeon and I ask them, how much do you want for a tonsillectomy? And of course they don't know, but I say, you're going to have to decide. This is an important exercise for you to declare your worth and understand we've all locked arms. It's kumbaya. If anybody gets greedy and out of control, then the bundled advertised price is not competitive. So as an anesthesiologist, I basically bill for my time. I had to come up with an amount of money per unit of time that made sense for me for the risk and skill that I think I have. And then for the surgery center, we're like a general contractor. It's time and materials. So I can look back at cruciate ligament reconstruction and tell you exactly what every single surgeon who does that spent cost-wise. And then I look at how long it takes. It doesn't take a rocket scientist to figure out what 15 or 30 minutes in an operating room fixed cost actually costs you. So it's not even algebra. It's just arithmetic. You add those things up and you get a number. And if you're nervous about it, then you pad it. You put a little bit more margin on there and then you go with it. And if it's wrong, looking back, you adjust.
I really love that comparison of a medical center and surgical suite as a general contractor. And I think that really, like, using that comparison and imaging it that way and like visualizing it that way really lends credibility to the arguments that people like Rand Paul have made against universal health care as a removal of an individual sovereignty as service for labor. Because like when you look at healthcare as labor, it's a lot easier to visualize what he's saying, that if you have universal health care with the government running it, then you've deprived a person's ability to say no. You've basically turned doctors into slaves instead of contractors.
Yeah, he is very focused and very articulate when that topic comes up. I recommend everybody pay close attention to what he has to say about that.
Yeah, he's not the best on everything. Don't get me wrong. I count myself as a libertarian, and I'm not the biggest fan of Rand Paul. But when it does come to things like healthcare, he's never disappointed me. He's always been right on the money and made sense and like just communicated incredibly. But thinking about like insurance is just a service. Insurance is a service. Insurance is work. Healthcare is service. Healthcare is work. Healthcare is contractors providing a service. How did things get so out of control? Because it seems like that's pretty straightforward. And the United States has had a pretty like great history. Up until the 70s, we had the cheapest and best healthcare in the world. What happened?
Well, government happened. That's what always happens. The state can't get anything right. And this, to paraphrase the old great Harry Brown, this industry is far too important to involve the most corrupt machine invented by man, and that would be the state. So, Medicare happened in the 60s. That was really a market distortion that cannot be overestimated. There also were wage and price controls under Roosevelt, so that employers, in order to attract employees, had to offer fat health benefits. There also was this Hill-Burton Act in the late 50s, thank you, Harry Truman, which put hospitals basically in every county in the United States, whether there was a market for them or not. That crowded out the hospitals that did exist for which there was a market. So the actual market-based hospitals, most of which were physician-owned, were crowded out. And government started paying for care through the entitlement programs, Medicare and Medicaid, and things rocked along in spite of government. The market is resilient after all. And then Nixon signed the HMO Act, and that really let loose the dogs. And that, then the PPOs were born, and, game on. Bill Clinton didn't help anything with HIPAA and all the other stuff that came out of his outfit. And then, of course, one of the crowning blows was the Unaffordable Care Act, which is a disaster, and is why we only have 4 health insurance companies now. I guess 5 if you include Humana. But the consolidation of industry that occurred after the Unaffordable Care Act was extraordinary. But that's sort of where it went wrong, and it was the government, and they do what they do. I mean, they auction off favors to these cronies, and we can slap insurance in the hospitals and big pharma around, and they deserve it. But all they're doing is just ponying up, trying to buy favors so they can achieve, a better advantage in this sick, cartelized industry.
And that's really what it's come down to. It's everything has become a cartel. I'm not that old. I'm only 32 years old. But I remember even when I was a kid, not that long ago, that in the town I grew up in, there were 5 or 6 doctor's offices just around town where primary care, or there was ENT doctor that just had a private office where they saw people. And I don't see any of that anymore in New England, where I live. All of the local doctor's offices have gone out of business. One of the ones I used to remember is now a bicycle shop, where the doctor's office used to be. And doctors seem to be just coalescing into these large medical practices. And the only justification I have for it is, well, that's the only way they can afford their overhead, because their overhead and dealing with the regulations has gotten so out of control that it's impossible for a private doctor to be private anymore.
Yeah, there's absolutely been a war on private practice, independent doctors. If doctors are employed, they're much easier to control. So the federal government has driven many independent physicians into the arms of hospital systems who then buy their practices on the cheap. And they've done this in a number of ways. Medicare pays a hospital employed doctor, not the doctor, but the hospital system, twice what they pay an independent doctor for the same service. That's not even subtle.
That's just something Medicare pays at all sometimes.
Yeah, but I mean, they pay the hospital employed doctors a ransom for the same service. Then there are all of the tools, the electronic health records, the ICD-10, all of the coding. It's just a nightmare. And then, the legal climate is not improving. The shark lawyers and the malpractice situation and the limits of financial devastation that physicians are exposed to, that's a real issue. So all of these things have caused a lot of physicians, particularly those who are a little bit older, that have a lot of clinical expertise and experience, some of which is undoubtedly life-saving for some patients in their past. A lot of these people are throwing up their hands and they're retiring, or they're going to work for a hospital. And of course, physicians are humans, and the incentive structure is all wrong. If you're going to pay me some salary, and really what I do is not related to that salary, I'm not going to do much. They say you hire a doctor and he goes to the beach, and we're no different than anybody else. But if I tell young medical students, if you're working for a hospital, you are not working for your patient. And that dilemma ultimately presents itself. Where do I do what my employer wants me to do for this patient, or do I do what's right for this patient? And that's not a dilemma any physician should ever be in, but it happens every day. A hospital employs, say, a surgeon who's horrible, but the primary care doctors who are employees, God help them if they refer one of their patients to a surgeon outside of the family, right, outside of that hospital system. Their job is in jeopardy. So they know the guy's awful, and they still have to refer to him. So the employment of physicians by hospital systems is really a bad trend. But once again, if you're ever looking for who is responsible, the answer is always the state. And you might be wrong, but that's a great place to start.
You can't say the state bears no responsibility, for sure.
No, they have total responsibility on that one, as far as I'm concerned.
Yeah. Now, one of the things, like, people love to blame insurance companies. People are always like, it's the insurance companies, it's the insurance companies, it's the insurance companies. The progressive left, when they come at it, it's always the insurance companies. One of the things that's mind-blowing to me when debating with people who come from the progressive left in politics is that they understand the problems, and a lot of the problems that we're facing with. And I agree with them wholeheartedly on the problems. Like, when I hear Alexandria Ocasio-Cortez going on about the problems with healthcare in this country, I'm like, yeah, you're right. You're completely right. And then she starts talking about how to fix them. I'm like, no, not that. But it's always pinning blame on insurance companies. It's always pinning blame on big pharma. It's never pinning blame on the regulations that caused this cascade. And as you said, it wasn't just one. It was one after another, after another, after another. And I feel like there's almost a social explanation to explain the desire for Medicare, if not the need for it, when it came down to it, where people felt a responsibility to care for the elderly and the infirm. And some people do see that as one of the few roles of government. Okay, that makes sense. But then it caused problems, so they passed a new law to fix the problems it caused. Then they passed a new law to fix the problems that caused, and passed a new law to fix the problems that caused. And in the mess, we're left with the thousands of pages of regulations to run a family practice.
Yeah, this is an old argument. Are the people who run the state stupid, or are they evil? And I think they're both.
At what point does stupidity and incompetence become malicious? Like, because if you recognize the stupidity, if you recognize the incompetence, at what point does allowing it to continue constitute evil? Is how I would approach that.
Yeah, and you just think about it from a straight economic stance. Thomas Sowell said he was always fascinated that no one thought that we could afford health care for people in the United States, but somehow we could afford their health care plus a bureaucracy to run it. That didn't make any sense. So, if you could turn the clocks back, there's a lot of things that would be different. Legislators have asked me, what can we do? And I tell them, first, stop. Stop what you're doing. But if you want to do anything, then repeal what's been done in the past and dial it back.
And I love that approach. Just repeal. Like, why don't we get back to the market that we had?
Yeah, I like, Murray Rothbard did not think there was such a thing as good government policy. But I disagree. Good government policy is that which repeals prior government policy.
Yeah. Just a couple weeks ago, I was approached by a state representative here in New Hampshire because I'm fairly known in the local community for my expertise on healthcare. A lot of libertarians in the area come to me for help and advice with their insurance and what they're doing. And I'll never do it. I'll never write a plan for a friend or take a commission on a friend, but I'll give people advice willingly and freely. I've spent years generating the knowledge. I might as well use it. And a state rep came to me and said, you know what? I want to submit some bills to fix healthcare. How can we fix healthcare here in the state of New Hampshire? And I'm like, you know what? I'm going to have to do some research and see what the actual problems are and get back to you. And a couple days later, I emailed them like, you know what? Here's a list of things to just repeal. We'll see where we go with that. And I just got an email from him today. He submitted the bill, itemized a whole bunch of restrictions to repeal in the state statutes. The first one he's going after is the prohibition on short-term underwritten medical care.
Good.
Because that prohibits people from getting private insurance that's medically underwritten in New Hampshire.
Yeah, who benefits from that?
Nobody.
Yeah, well, I mean, who benefits from that being in law, that prohibition being in law? And it's the big carriers. I mean, they don't want that. They don't want people to have choice. So good for him. Certificate of need laws, those all need to be. I mean, are you kidding me? Explain that so that it makes sense. I mean, you can't defend that. It's not subtle at all.
It really does highlight every time. Like I've only seen it a few times in places where I've lived. Again, I'm not that old, only 32 years, where like a new hospital or a new urgent care or something pops up that and certificate of need becomes a thing that people even know about. And I remember the town I grew up in North Attleboro, Massachusetts. It's after I was off at college. I came home one weekend and I asked my mom, what the hell's going on here? Because there had just been a big dug parking lot. The foundation was done and then they stopped construction for like 6 months. And she's like, oh, they're fighting over whether or not CVS can build an urgent care there. I'm like, why wouldn't CVS be able to build an urgent care there? She's like, sturdy hospitals objecting to it.
Right.
Like the local hospital was objecting to a new urgent care 10 miles away.
Well, and there's a lot of money flying through the legislature to make that happen. I mean, once again, the state is the problem. And sometimes it's at the state and local level just wherever new entrants, encounter these barriers, that usually means the state is protecting one of its cronies.
Now, the state protecting people, that's what the state does. And unfortunately, it's never the people that it should be protecting that it's protecting. It's the people who pay for the state the most. Everything you're doing and everything you're preaching is most certainly a threat to the system as it is. How has the state tried to deal with you and what you're doing?
Well, we've made it hard on them because we don't accept their money. If you don't take their money, they don't have a hammer to hit you with. They really struggle with how are we going to mete out consequences for this uncooperative maverick? And then when you don't take their money, they're sort of befuddled. So they have done things, though. I mean, they tried to pass a law in the state of Oklahoma that required 30% of my revenue to come from the government. And to the extent that I was not in compliance, I owed a fine for whatever percentage of non-compliance of my gross receipts. Well, that meant they would be combing through our books and they would be assessing a penalty of 30% because I'm a strict property rights person and we're just not going to accept stolen property. So that bill went down in flames, fortunately, because as crazy as this sounds, we had a Democrat on our side. His name is Fred Stanley, and he was a great man. He's still alive, and he saw us as the underdog, and he did not like this big, fat, crony, corporate sort of medicine. He saw us as the champion of the poor, and he stood in front of this effort and stopped it. The hospitals weaponized the state health department to come after us because ultimately I have a state license as a facility.
Right.
The state health department came after us and told us they wanted the medical records of all the patients in our facility in the year 2000. And I told them no. And they said, you don't get to tell us no. We're the state health department. And I said, hell no. And they said, then you're closed. And I said, and we'll have an injunction filed by late this afternoon. Let's go. Let's go to the mat. So we had some discovery. We sued them. And it turned out they did not have the statutory authority to collect these records. And everybody else in the state turned their records over to them because they were sued, and we refused to. And I have their surrender framed on the wall in my office. But most of the things they tried to do blew up in their face and kind of backfired on them. They did stumble upon a formula that really hurt us in about 2004 when the insurance commissioner looked the other way and allowed the carriers to stack deductibles. So we've been excluded from insurance networks from day one. There was a very brief period of time we were in network with one carrier, and that was a disaster. I regret that. But patients would come to us because our entire price was less than their in-network deductible. And
that's the crazy part to me. Your entire price is less than the deductible for something that they're already paying tens of thousands of dollars for a year. And to harken back on something you said, like the Democrats saw you as the champion of the poor. The biggest criticism I see of what you do, and I think it's a wildly unfounded criticism from everything I've seen, is people saying that, oh, that's great for the rich who can afford that money up front and out of pocket. But it's not the rich that are going to you, is it?
No, give me your poor, tired masses. I mean, the Surgery Center of Oklahoma is the oasis that people have found who've been run off by these so-called not-for-profit hospitals and their pricing, which is 6 to 10x what mine is. So we're actually able to provide care for a reasonable price. But when they stacked deductibles, they told patients you don't have any insurance benefit out of network unless you've already met your in-network deductible.
Jesus.
So that just about killed us. But no, I mean, poor people, we see people that you and I and everybody listening to this show would categorize as poor. We see them all the time. And when they're poor, sometimes a hospital doesn't want to see them, or they tell the doctors who are their employees that they need to slow play this. We don't need to see them. So a lot of the poor go on waiting lists, like the Canadians we see that are in a 2 or 3 year line to get a hysterectomy so they don't have to have blood transfusions anymore. This wonderful Canadian system, and we have Canadians in Oklahoma City having surgery. What else do you need to know? So, yeah, I mean, the poor, I mean, they love us.
I feel like there's so much good and bad on each side of the border there, that it makes for like almost a hodgepodge. If you live on the Canadian border, you can almost like work out getting good healthcare, because like you can get quality healthcare if you're insured through your employer or whatever in the United States, and then drive 15 minutes to go pick up your prescriptions in Toronto and not have to pay outrageous prices for insulin and inhalers and stuff like that. But the pharmaceutical industrial complex is a whole different conversation that I think has more to do with IP laws than medical. But like, it's crazy to me, because what I've seen from the insurance side is poor people just not getting coverage, because poor people working multiple part-time jobs or in a gig economy, and the only option they have is Obamacare. They don't have anything employer sponsored, and so they just don't have insurance. So they don't have an in-network doctor to go to. So their primary care is urgent care in the emergency room, which is the most expensive way to get health care. And the justification that I see politically, the justification that I see socially, and the justification that I see in my offices with my coworkers is that it makes sense that hospitals overcharge for all of this, because hospitals have to make up for what they're not getting from the poor people. And that just blows my mind, because it's overcharged to begin with. And if the prices were like yours, just transparent and upfront, the poor people, maybe they're poor because they can't afford the hospital, but they wouldn't be poor if they could afford it.
Well, understand that coverage doesn't mean care. I mean, look at the Canadians. They all have coverage, and they're all in Oklahoma City. So, I joke. I said the people in Canada have come to finally understand the only single payer they can truly rely on is themselves, because they have to travel to get the care that so many of them need. So here's a quick version of why cost shifting, which is what you described, where hospitals overcharge to make up for all of their losses. Here's how it really works. Hospitals file these big claims, for $100,000, and then they don't get paid, or Blue Cross pays them $20,000. The hospital then claims they lost $80,000. Now, never mind, they were charging $100 for an aspirin, to get to $20,000. So they've made out like bandits, even though they claim that they've lost $80,000. That's because they billed $100 and maybe only got $20. Well, that $80,000 loss serves to prop up the fiction of their not-for-profit status. And they're looking for red ink wherever they can find it, because they're all making so darn much money, except for the rural hospitals who've been victimized by the big boys. Here's the other thing people don't know. All of these losses, this $80,000 they didn't collect goes in a bucket and gets shipped off to Washington, D.C., and Medicare gives them a kickback to the extent that they claim these losses. So that's called uncompensated care, or disproportionate share hospital payments. So I like to say hospitals are paid even when they aren't paid. So to the extent that they claim these losses, they actually collect. So the whole idea that they need to overcharge someone because they didn't collect on the poor is insane. Also, they don't pay tax. These not-for-profit hospitals do not pay tax. So, what happens to your standard of living if you're not paying tax? So all of those, these poor hospitals, how are they going to get by? Give me a break. I mean, there's a crane building onto the ER of every one of them. They're buying out competitors, buying physician hospitals, buying ads on TV. They're doing, particularly the big box hospitals, they are doing just fine.
So I do have a comment in chat I want to bring up. It's from Dogerat, and I know Dogerat. Doge is from Canada. I don't agree with that statement. You just don't have to worry about getting top care. No matter what happens, you're covered and get care quickly. I have seen it my entire life. I think the point you're making is like they do emergency care pretty quickly in Canada. It's things that would be considered elective care that they push off until they become a problem.
So do we. So we have a Canadian coming next week who's in a 3-year line to see a gynecologist for a hysterectomy, and she's tired of getting transfusions. I mean, so whenever we have a Canadian come to the Surgery Center of Oklahoma, I've learned my lesson. I cannot sympathize with them about how their system has let them down. Those are fighting words. They'll defend that system in Oklahoma City. I mean, looking at me as a forlorn patient, they'll defend that system. My good friend who lives in Canada tells the old joke that no Canadian's truly happy unless they're standing in line. And this pretty harsh, but I don't know, maybe there's some truth to that. But I think this socialized system in Canada is some sort of national pride thing. I think that it's like nationalism. It's some version of a mental illness, and they just can't get past it. They will continue to defend it, even if they're in Oklahoma City paying cash for their operation.
Well, Dogerat does bring up an example from their own family perspective. One example in my life, a family member diagnosed with prostate cancer, got all tests, called immediately with doctor, into surgery within a few days. Doctor visits as much as prescribed needed. I feel like the point there to dissuade any conflict between what you're saying and what Doge brings up is that they are really good at getting real emergencies treated, at getting real emergencies to the front of the line, and people who can't wait. The problem is things that are considered elective or not very high on the priority list get pushed back every time a real emergency happens to cut in front of them.
So there's a big public park across the street from one of the major Canadian hospitals where people are jogging in order to have an MI, to have a myocardial infarction, so that they will not have to wait, so that they'll go to the emergency list because they don't want to wait 18 to 24 months for their life-changing angina and their chest pain to just go away on its own. So there are people out there running around, walking fast and jogging, hoping to have a cardiac event so that they can get to the ER and be treated quickly. The system is a disaster. One story of a patient who got prompt care, good for them. That's great. Yeah. But when millions of Canadians, including top government officials, are traveling to the United States to get their care, when Canadians are at the Surgery Center of Oklahoma, something's wrong. I mean, there's a supply and demand issue if people are doing that.
I mean, not to get all dark humor on it, as much as I love dark humor, but I almost feel like people running and doing exercise every day might lower their risk of a heart issue if that's what they're waiting for. And like maybe they're doing self-treatment there as well. And maybe some lives are getting saved by the fact that they started exercising. But to move on from that, and Doge continues to disagree, but he does appreciate your opinion, and that's why I like Doge on the channel. We never agree, but he's always here and never disrespectful. But to your point, yeah, I remember a huge outrage, and like people were losing their minds on Twitter and Facebook when a British Prime Minister was coming to Boston for heart surgery. It's like, well, what's wrong with the hospitals in England? It just didn't have any openings, and even I don't even necessarily think that's a Canadian exclusive problem or a British exclusive problem. We see that in the United States with like transplant lists, where people are ranked on a transplant list based off other factors, some that aren't in their control. Like I have a family member who's pretty low on the transplant list for her kidney because she has diabetes. That's not in her control. And there's an old TV show that I thought was fascinating. They covered this in a episode where one of the characters needed a transplant because of his years of drug use. He was like bottom of the transplant list. And then while trying to do a drug deal to get money to purchase a black market kidney, he got stabbed and in the emergency room got moved up the transplant list.
That's so crazy.
Right. But like I had to look it up, and it turns out that's how that works. A true emergency will move you to the front of the list. So people running to give themselves a heart attack just so they can get into for a treatment doesn't faze me, but it wouldn't faze me in Chicago. Never mind Montreal or Toronto.
Yeah, I heard from a young lady in Vancouver when I was asked to speak up there because the number of Canadians having surgery in Oklahoma City was so remarkable. Someone asked me to actually come to Vancouver and give a talk about what our experience was. And there were a number of Canadians there who described their experience in the system. And there was a young lady whose 15-month-old daughter developed an ear infection, and they could not get her in to see an ear, nose, and throat doctor. They were told it would be several weeks. The antibiotics were not working. This kid needed to have a tube put in their ear, and the kid wound up with a life-altering brain abscess because this was untreated. I mean, they were just pushed aside. And this is in Vancouver. I mean, this is not out in the sticks. This is in Vancouver. And I heard the story from this lady. There's a Reason magazine, Reason TV video about a woman who I met at this conference talking about her experience trying to have a hip replacement in the Canadian system. And these are real disaster kind of stories. And I'm not saying the system in the United States is any good. It's awful. But what we don't want is to substitute market rationing for bureaucrat rationing. There's always going to be rationing because resources are limited. So you have to choose. Do you want a bureaucrat to ration, or do you want the market to ration? And the reason I choose the market is it's the most efficient use of resources. So people tend to get more of what they want at a lower cost.
Now, speaking of like market rationing and supply dwindling and access issues, it's amazing. We're almost an hour in, and it's the first time I've had a doctor on the show, and we haven't talked about COVID. How do you see the market responding to like staffing shortages in medical care right now? Because you have this perfect storm of certificate of needs creating a limited number of hospitals and a limited number of hospital networks, and the cost of education and the AMA arbitrarily limiting the number of doctors and new professionals entering the workforce each year, and restrictive licensing restricting the number of nursing students admitted as nurses every year. And all of a sudden, you're having people walking off the job and quitting, some because of risk and they don't want to be exposed to COVID, and some because of mandates and they don't want COVID vaccines. And so we're seeing a huge shortage of medical staff in realistically necessary and critical facilities for the community. And I know it's a huge problem here in New Hampshire. We just had 100 or so nurses walk off the job at Dartmouth Hitchcock Medical Center, the biggest hospital in the state. and there's a huge exodus happening in Massachusetts even. How is that going to affect the market? Has it affected your market? Have you had to deal with anything like that at OKC? Is the government putting in new mandates on treatment because of COVID that's affecting your facility and your staff? And has there been any market response from staff or patients about either your lack of compliance or compliance with the state mandates?
Yeah, I mean, once again, the market's like gravity. So if you're in sync with it, you reap its bounty. And if you're not, then you see exactly what you just described. I talked to a hospital administrator yesterday. It may shock you or your listeners to know that I actually have friends who are hospital administrators, but
doesn't shock me. I have a lot of friends who are insurance company underwriters. When you've been in the industry, your politics don't end your friendships. Yeah,
and I was told that there's no shortage of beds. There's just a shortage of staff beds.
Yep.
But yeah, I mean, it's getting increasingly difficult to hire nurses and to find physicians who are willing to work in this risk-benefit structure. Now, at my facility, we don't accept federal money. So, there's no mandates of any kind. At my facility, we had 3 positions that were open and they filled overnight. Because it's a great place to work, and I don't like mandates. I don't like mandates of any kind. Say government is that institution whose ideas are so wonderful they have to be mandatory. So I don't like mandates. I don't like to tell people do this or else, which is exactly what a mandate is. But yeah, it is harder and harder for hospitals to find staff. Part of the reason too is hospitals have not treated their staff very well over the years. So they'd already kind of redlined some of these people on their tolerance. And they already had one foot out the door before COVID or any of these mandates came along.
Yeah, and to your point, like it's getting difficult to hire them because of how they were treated. One of the responses that I have seen that I think is most terrifying, because we keep going back to the push for socialized medicine, the push for single payer, and like the push for complete and utter government control over the medical system in this country, is I think it's Massachusetts and maybe a couple other states have activated the National Guard and are using members of the military to fill staffing shortages at hospitals.
It's incredible.
Which are private hospitals, nonprofit or not, that are now being staffed by members of the military. And to me, that's one of the most terrifying things, because it's a direct line of government control over people's health care by putting them as employees of the government in the United States military in charge of people's direct care.
In any other industry, that CEO would be fired for their inability to maintain an operating staff. So it's incredible.
It really is. And it just goes to show like how non-market responsive the medical industry really is today. But that doesn't mean it can't be. You've shown that it can be. What you've done in Oklahoma has shown that it can be. And you're not the only one doing it. We're seeing a resurgence of direct primary care here in New Hampshire. I don't think it's very common in Massachusetts or Vermont, where they're still pushing for socialized medicine at the state level. Right. But like that's something that's becoming more and more common and more popular with people, is things like direct primary care and health ministries and mutual aid, as opposed to big insurance groups and government control. What is your outlook? Is positive, neutral? Like, what kind of a timeline, or what's your forward-looking outlook on free market healthcare in the United States today?
Yeah, I'm actually very optimistic. The direct primary care movement is growing. It's growing at an incredible pace. The Free Market Medical Association is the kind of the tent under which all of those who are like-minded, like me, are gathering. That organization is growing at a very, very rapid pace. Ron Paul was our keynote 2 years ago, and Steve Forbes was actually our keynote at this last conference, waived his honorarium and just was blown away by what he saw. So I'm actually very optimistic. I think we're seeing what Jeff Deist at the Mises Institute refers to as soft secession. I think we're seeing states push back. They're pushing back on marijuana laws. They're pushing back on all kinds of stuff. They're suing the White House over these mandates. They're basically pushing back on all kinds of federal intrusions. So as the states become a little more powerful, a little less scared of Uncle Sam, then there's the opportunity for more innovation and more of a kind of a federalism. So I'm optimistic. I like what I'm seeing. There are a lot of people that have lost faith in the state as the great protector. You know, Albert Camus said that the welfare of the masses is always the alibi of tyrants. And I think more and more people are coming to grips with that, and they're seeing how the state has handled a pandemic, and it's a disaster. So as the government loses all credibility and we give it the contempt and ridicule that it deserves, then we're more free. And I think that's happening in the medical industry. I think people know something's up, something stinks. I think they know who's responsible. And I think things are going the right direction. I'm a member of a health sharing ministry, and I'm a big fan of direct primary care. And that's very disruptive to the players who've paid a lot of money for the privileges that they've gained from DC.
All right. Well, as fascinating as this conversation has been, it's been incredible. It's been insightful, and I hope everyone watching has gotten as much out of it as I have. I've kept you over the hour that I invited you here for and asked you to be here, and I don't want to keep you too long. So is there anything else you want to leave people with before we go? Any final parting words?
Yeah, I would encourage people to look at our website before you have surgery somewhere else, particularly if you have sticker shock and you want to save some money. There's another website called atlasbillingcompany.com. That's where I have listed a lot of prices for inpatient surgery. I would encourage people to look at that. And then maybe most important, look at the Free Market Medical Association, fmma.org. There's a tab there called Shop Health, and that is a great place to look at prices. And you ought to look that over if you're going to be out of pocket on any kind of medical care, surgical or otherwise.
And always remember, everybody, if you're on Twitter and social media, which I know most of you are, you can follow the Oklahoma Surgical Center of Oklahoma on Twitter. They post not the most regularly, but great to keep up with what they're doing and what they're doing activist-wise. Again, Dr. Smith, it has been so awesome to have you here tonight, and it's been a fantastic conversation. I cannot wait to publish this out to other platforms for people to see. But again, I'm hoping we can get you to New Hampshire sometime for a conference that we're having and speak up here. And other than that, I just want to thank you again for coming. But we're going to wrap up the show tonight. So till next time, everybody, be free. Thanks again for tuning in and joining the show tonight. Make sure you hit that subscribe button and keep up to date with future shows. Leave a comment below to let us know your thoughts about the show tonight. If you enjoyed the show, you can join our production team over on Patreon by following the link in the description. And don't forget to join our community Discord channel to keep in touch between shows. The best part of all of this is the community that we build around it. And thanks once again to our awesome sponsors and fantastic patrons for helping to keep this show going. If you can't catch the show live, you can always check them out the next day on YouTube, Odyssey, Spotify, Apple Podcast Breaker, and all your other favorite podcatchers. So until next time, everyone, be free.